Hi, human physiology students. This is going to be the third installment, third video that accompanies the Chapter 4, Part 1, Neurotransmitters and Signaling. So the other two installments, the first two YouTube videos on my webpage are already up. So I'm going to share my screen and I'll let you know where we left off with that second YouTube video. Okay, so we left off here. All right, so last video, it was about how neurotransmitters bind to a receptor. They open up an ion channel, and depending if that ion channel is sodium or calcium, that will always stimulate a cell. And if it opens up a potassium or a chloride ion channel, that will inhibit or cause a cell to rest. We also talked about cell stimulation. It's called an excitatory postsynaptic potential, EPSP for short. And we talked about how that could be a graded potential or show summation. And then we left off with two types of receptors, nicotinic and muscarinic. Remember, nicotinic is for voluntary responses. Muscarinic is for you must. All autonomic responses happen through these types of receptors. And then we talked about the importance of enzyme removal systems. So now we're going to move on to something new. Neurotransmitters and what they're derived from chemically. You're not going to have to know any chemical formulas, but it helps to know where these neurotransmitters come from. So we'll start with choline derived. So that's going to be acetylcholine, which is abbreviated ACh. Now these two boxes I've got, one over here on the left is for neurotransmitters you'll find in the brain and the spinal cord. And the plus signal that you see is this neurotransmitter is stimulatory, and if there's a minus, it means it's an inhibitory neurotransmitter. Another way of looking at this is if that neurotransmitter binds to a receptor, if it opens up sodium or calcium channels, it stimulates. If it opens up potassium or chloride ion channels, that's how it inhibits. Okay, on the right here is neurotransmitters that you find outside the spinal cord in the rest of the body. Okay, so for acetylcholine, notice it's got a positive sign. That means it's stimulatory. So acetylcholine in your brain and spinal cord is always going to be stimulating. Now, in your peripheral nervous system, acetylcholine plays a role in, well, I don't have it here, I should add it. Acetylcholine is how all of your skeletal muscles contract. I think I've talked about this before. So acetylcholine, when it binds to its receptor on your skeletal muscle cells, will always open up the sodium channel. And that's always going to make your skeletal muscles contract. So that is missing from this slide, but I'll have it in my notes. Now, acetylcholine also regulates your autonomic parasympathetic response. So this is the autonomic functions that happen to your body under rest and digest. And we're going to be spending a lot more time about that in a few slides to come. So it can be stimulatory and it can also be inhibitory. It can do both those things. So I'll explain that later. The next neurotransmitters are going to be derived from monoamines. That's a amino acid. And so these come under the heading of catecholines, and that will include norepinephrine, which in your brain and spinal cord is always stimulating, dopamine, which can stimulate or inhibit, but I'm not going to get into that detail, and I'm also not going to get into the detail of is serotonin purely stimulatory or inhibitory. I'm just going to talk more about what these neurotransmitters do and why they're important, especially when there's abnormal levels of these neurotransmitters. Some of the most common psychological, pharmacological drugs that are administered to people have to do with dopamine or serotonin disorders. Okay, now in your peripheral nervous system, it's called epinephrine. It does the same thing. It can be stimulatory, and it's part of your autonomic fight-flight system. So when your life is in danger, it's going to control all the autonomic body functions that happen to you during fight-flight. But it can stimulate some things and it can inhibit others, and we'll cover that later. All right, the third class of neurotransmitters come from some other amino acid other than monoamines. So there's three, the three G's. Glutamate is always stimulatory in the brain, all right? Glycine is primarily found in the spinal cord, and it is inhibitory. And then GABA is also inhibitory, and that is in your brain, primarily in your brain. And use the acronym GABA rather than trying to say the whole name out loud. Okay, Now, the last class I'm going to cover, there's not a limit. These are not the only neurotransmitter classes, but that's all I'm going to cover. But nitric oxide is a gaseous neurotransmitter in both your brain, spinal cord, and your peripheral nervous system, and we'll cover this at the end of this chapter. So let's start at the top. Acetylcholine signaling. It's a pretty big one. So acetylcholine signaling, it is found both in the central nervous system and your peripheral nervous system. In your central nervous system, it's always going to be stimulating. Now, in the peripheral nervous system, it can stimulate some things, but inhibit others, and I'll try and explain that to you. So, remember how we talked about the importance of breakdown of neurotransmitters? Acetylcholine is broken down by an enzyme called acetylcholinesterase. So, like I always do, if you look at the word in reverse, A's means enzyme, and acetylcholine is what that enzyme's breaking down. Sometimes people just call it cholinesterase, all right, but it's for breaking down acetylcholine. All right, that's review. So there's going to be two types of cholinergic receptors. They're just called cholinergic, but when you say acetylcholine and call it a cholinergic receptor, the receptor is named after the neurotransmitter that binds to it. So if it's called cholinergic, it's for acetylcholine. Okay, so nicotinic cholinergic receptors. We covered this in the previous lecture. It's for control of your skeletal muscles. They all have this kind of cholinergic receptor on them. So they bind to acetylcholine. So at your neuromuscular junction, which is where a somatic motor neuron stimulates a muscle cell, that muscle cell is going to have a cholinergic receptor on it. And the particular name for this cholinergic receptor is nicotinic. Now, in a previous lecture, I've used the cigarette to make you remember that it's nicotinic cholinergic receptors that you have in your skeletal muscles, because you have to voluntarily pick up a cigarette to smoke it, and that takes voluntary control. So think nicotine found in a cigarette is for nicotinic cholinergic receptors on your skeletal muscles. And this receptor, when it binds to acetylcholine, will always open up sodium channels, all right? So it's always going to be stimulatory, and that's how all our skeletal muscles work. Now, that's the only nicotinic cholinergic receptor I'm going to teach you. There's more, but it's not necessary. Let's go on to the next type of cholinergic receptor. That is going to be muscarinic cholinergic receptor. And if you remember, muscarinic means you must. You have no voluntary control. It's for autonomic control of your body. And a muscarinic cholinergic receptor, I've got a mistake here that I'm going to have to fix. Let me do that now. It is for acetylcholine. Let's cross that out. I didn't look at my PowerPoints before doing this. If it's a cholinergic receptor, it's only for acetylcholine. So notice I crossed off epinephrine. My bad. So this is a receptor for acetylcholine that's found on muscle cells and glands that you have no control over. And that includes heart cells. That includes smooth muscle cells in your body, and that includes gland cells. You have no control over these things. So it's for autonomic parasympathetic regulation of your heart, your smooth muscle throughout your body, and glands. So if that cholinergic receptor binds to acetylcholine, it could slow some things down or inhibit some things. So if it's binding to a cholinergic receptor on your heart muscle, it's actually going to inhibit the heart rate's going to go down, because it's actually going to be primarily potassium channels. So I'm going to fix something while I'm here too. All right, acetylcholine would open up, there we go, potassium channels on the heart, not chloride, but on the heart it's potassium. Now, if it binds to a cholinergic receptor on some other things like smooth muscle in your GI tract, even smooth muscle in your bronchioles or gland cells, it can speed up that activity, okay? Because what will happen is when it binds to a cholinergic receptor on your GI tract smooth muscle, it opens up sodium and calcium channels, and those are stimulatory. So what acetylcholine will do to your GI tract, it will speed it up. It'll increase the rate at which peristalsis occurs, all right? And other smooth muscle, it could stimulate your bronchial muscle to respond as well. It'll cause it to bronchoconstrict a little bit. So acetylcholine can be both stimulatory especially for GI functions, and it can be inhibitory on other things like your cardiac muscle. So now that I've introduced a little bit about acetylcholine, it's two types of receptors, nicotinic and muscarinic. Let's talk about some pharmacological terms that you're going to know in nursing school. An agonist versus an antagonist. An agonist is any drug or substance that can increase the level or activity of a neurotransmitter, or it can even stimulate its receptor. So an agonist causes more of that activity to happen with that neurotransmitter. Now an antagonist, think of it like a blocker. It's going to decrease the levels of or activity of a neurotransmitter or block its receptor. Now you've probably heard of blockers before if you have any family members or people that you know that are on beta blockers for high blood pressure. So I'm going to teach you what that blocker does. All right, let's move on. So let's talk about what happens when acetylcholine is supposed to be broken down by acetylcholinesterase. Sometimes you can be exposed to something that prevents acetylcholine from being broken down by acetylcholinesterase. So it's an acetylcholinesterase inhibitor. And this is bad. I've given a story before when I was working at a vet clinic that a dog came in, it had those muscle seizures, it was salivating, it urinated and defecated all over itself, and it was in dire straits. And come to find out, the owner had overdosed the dog with an acetylcholinesterase pesticide for fleas and ticks. And so this dog was critical. We saved it, but let's talk about what happens when acetylcholinesterase can't break down acetylcholine like it's supposed to do. So an acetylcholinesterase inhibitor is something that blocks enzyme acetylcholine breakdown. Remember, you need to be able to break down acetylcholine after it's done its job and get it out of the synapse, because if you don't, it keeps stimulating or inhibiting whatever it does. So when you have an inhibitor of that enzyme, you'll have a buildup of acetylcholine in the synapse with skeletal muscles, cardiac muscle, GI tract smooth muscle, all glands, all that stuff, anything that acetylcholine could stimulate or inhibit. And so with all that excess acetylcholine, you would have cholinergic syndrome, too much acetylcholine. So let me ask you a question. Is the acetylcholinesterase inhibitor an acetylcholine agonist or an antagonist? To answer this question, you're probably thinking about it. Does it increase the amount of that neurotransmitter or does it decrease? It increases it, so it makes it an agonist. All right, so the answer is it's an agonist. Okay, so I'm going to give you 3 examples of an acetylcholinesterase inhibitor. All right, it's a bad thing in some circumstances. So organophosphate pesticides, like this dog was exposed to. You can be exposed to malathion. Well, hey, if you're outside and they're spraying, they use a truck in the city, will go down spraying streets when the mosquitoes are bad. You don't want to be outside in that cloud of malathion because it can cause cholinergic syndrome. Now, carbamate is a general insecticide that people can spray on their crops. So we are in an agricultural area in the PD here, and this could happen. A farmer could be filling up the vats on his tractor, and if he spills any of that carbamate on himself, it could drive him into, or her, into cholinergic syndrome. So that is something that could happen. Now, chlorpyrifos, or Durisban, got banned for use in flea and tick meds in the United States in 2000, before you were born, because they knew it was causing cholinergic syndrome in animals. So the only way you might see it as nurses is if someone gets exposed to malathion, carbamate, or some other organophosphate pesticide. Well, here's another possible exposure, and since I'm a former vet tech, you have to be really careful about medications, flea medications that contain pyrethrins. This is right here, it says 0.2% pyrethrin. Now, interestingly enough, it's okay to use pyrethrins in dogs because it acts differently in them, but don't ever give it to a cat because pyrethrins in cats, it acts as an acetylcholinesterase inhibitor, and it could kill a cat with cholinergic syndrome. So just a little factoid if you have animals. Watch out for pyrethrins in cats. Okay, last example, not all of them, but the last one I'm going to cover. Sarin gas is a weaponized gas used as a biological weapon. All right, it has been used in other countries, and there's a clinical app for it online, which, if you click this app, comes up right here when you're online, and it says nerve gas exerts its odious effects by inhibiting acetylcholinesterase, okay, in skeletal muscles and other things. It's not just skeletal muscles, it's anything that acetylcholine can signal. Clinically, cholinesterase inhibitors, oh look, they give an actual pharmacological drug that I'll talk about later. Neostigmine are used to enhance the effects of acetylcholine when people have disorders like myasthenia gravis. So let me get back out of this and go back to the PowerPoint. Okay, so what I'm giving you right now is the dangerous effects of an acetylcholinesterase inhibitor when it's an accident, like poisoning. So sarin gas was used back in the 90s. There was a terrorist group that basically released sarin gas on a subway, and 5,000 people were injured, 12 people died. It's a pretty horrible way to go. I'll explain later. And then more recently, 2012, Syria, the government was threatened to use sarin chemical warfare against their own people because they were rebelling. And then in 2013, there actually was an attack in Syria, rockets to surface. So they actually dropped sarin gas, and 3,600 people were hospitalized, estimated a huge death estimated from neurotoxicity. Okay, so if you got exposed to sarin gas, probably wouldn't even get you to the hospital fast enough to save you. But here is what you can do to reverse cholinergic syndrome. Before I do, let's talk about the symptoms of cholinergic syndrome. Okay, so obviously this is someone spraying herbicides on a field. This is the same salad dressing. But here's the clinical presentation of someone with cholinergic syndrome. And there's a mnemonic for it. You'll learn lots of mnemonics. So dumbbells. So each letter stands for one of the clinical presentations of a person with cholinergic syndrome. Okay, and I'll explain why you have this. Diarrhea. Your GI system is stimulated by acetylcholine. Acetylcholine binding to muscarinic cholinergic receptors will increase peristalsis in your GI tract. If there's too much acetylcholine, your GI tract goes spastic and it's pushing things through too fast, and so you'll have diarrhea. Urination. Acetylcholine is involved in stimulating your bladder muscle, and it does also affect your urinary sphincters, so you could pee on yourself. Meiosis is constricted pupil. So that would certainly, if someone's on a drug or they've got cholinergic syndrome. Now, I believe I've covered this before. Your heart is inhibited, your heart rate goes down when acetylcholine binds to muscarinic cholinergic receptors on your heart. Okay, so slow down, beat, 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 beat. If you have too much acetylcholine, your heart rate's going to go dangerously low, bradycardia. Acetylcholine can also cause some constriction of your airways, the smooth muscle of your bronchioles, making it a little bit difficult to breathe, and that's called bronchoconstriction. So that's that B. Now, excitation stands for skeletal muscle seizures, all right? So acetylcholine binding to nicotinic cholinergic receptors on your skeletal muscles, that is always going to stimulate them. So too much acetylcholine at the synapse of skeletal muscles causes whole body seizures, and that can be very bad because if you seize for too long, your body temperature rises to a dangerous level. Now, lacrimation is tearing, your eyes water. Salivation, you know what that is. That's a GI function that ties into GI tract activities. And then sweating. The sweating is probably from the skeletal muscle seizures because your body temperature is rising. So dumbbells stands for all those things. Now, left untreated, cholinergic syndrome can certainly kill you. The bradycardia, your heart rate could drop too low, the bronchoconstriction, difficulty breathing, and then the increased body temperature from full body seizures, that could certainly kill someone. So, someone comes in with cholinergic syndrome. Here's what you want to have ready. So the treatment starts, well, it's three-pronged. So first of all, to reverse cholinergic syndrome, to reestablish the enzyme acetylcholinesterase, you give 2-PAM, pralidoxin. What this does is stops the it prevents the acetylcholinesterase inhibitor from not breaking down acetylcholine. Basically, in a short word, it basically makes acetylcholinesterase work again. Now, this is not going to be, you give the person an injection of 2-PAM and they're like, oh, I'm great, I'm ready to go, I mean, discharge me. No, while that drug is taking effect, you've got to do supportive care. This is where the nursing comes in. You've got to treat the other problems while this 2-PAM is doing its job in reestablishing acetylcholinesterase. So in the meantime, you want to treat the other symptoms that could kill a patient. So atropine, it basically, and there's a clinical app for it, it's an acetylcholine blocker. It will block the muscarinic cholinergic effects, such as it'll block the excess acetylcholine effect on your heart, so your bradycardia goes away and the heart rate goes faster. It'll block all the acetylcholine activity in the GI tract to stop the salivation, to stop the diarrhea, slow your GI tract down. It will reverse the, well, I shouldn't say that, it'll stop the urination, the eyes watering, all those things. So basically it stops the other symptoms of dumbbells. Now, what atropine won't really do though is treat the skeletal muscle seizures. So to treat that, because this is for muscarinic cholinergic responses, the atropine. For the nicotinic cholinergic responses, you need to give, I'll come back to that question in a second, you would need to give Valium, benzodiazepine. That will calm your skeletal muscles, it'll stop the seizures, and so the body temperature can come down. Now, what this drug does, Valium, is actually stimulates GABA. It's an inhibitory neurotransmitter in your brain. So it's working in your brain with a neurotransmitter that's meant to quiet your skeletal muscles, okay? So let me back up here to atropine. I asked here, is atropine an acetylcholine agonist or is it an antagonist? Is it a blocker? Well, it says here it blocks acetylcholine cholinergic receptor. So it's an acetylcholine antagonist. It's a blocker. Okay, so we applied a nursing situation to acetylcholine signaling and abnormal acetylcholine signaling. Okay, so now Valium. Question, is Valium a GABA agonist or an antagonist? Does it increase the activity of GABA or block it? And it looks here, it says it stimulates GABA. So Valium is a GABA agonist. All right, let's move on. Now, we're going to talk about some toxins other than things like sarin gas or organophosphate pesticides. And these are going to be other things. So toxins that are acetylcholine agonists cause more of an acetylcholine-like activity. So I've got a clinical app online for this. I'll let you look at that on your own. But tetanus is basically it's a bacterial toxin. It's caused by Clostridium tetani. You probably learned it in microbiology. Now the bacteria itself is not a problem, but the toxins that it releases into your bloodstream is. So how do you get tetanus? All of us in school here, even as pre-nursing students or in the nursing program, we all have to be tetanus vaccinated to be here. So if someone wasn't vaccinated or they let their vaccine wane, if you've got a deep puncture wound, that's how you can get tetanus bacteria into your body. And so what can happen is that the toxins act like an acetylcholine agonist. It causes what's known as muscle tetany. I like to call it hypertonia because tone means muscle tone and hyper means excess. So basically your muscles lock up, and that's why we have this classic textbook image of a person. They're not doing yoga, they're in full body tetany. And I'm sure if you've ever had a Charlie horse, do you know how painful that is? Imagine if all the muscles in your body locked up. I imagine it's pretty agonizing. One of the first symptoms is lockjaw, and that's where your masticatory muscles lock up. It's called trismus, and that's a sign that someone's got tetanus. Now, tetanus toxin is not only an acetylcholine agonist, but it also blocks glycine and GABA. Well, if you remember me mentioning that GABA is supposed to have your skeletal muscles relax, this tetanus toxin is hitting your skeletal muscles from all fronts. It's increasing acetylcholine and it's preventing GABA from letting your muscles relax. So you're supposed to be vaccinated for tetanus every 10 years. And if you get a puncture wound, they might, boost you with a vaccine. Now, what do you do if someone let their vaccine wane? Or I'll give you an idea. I had this happen with a goat. I keep goats, dairy goats, and I had a billy goat that cut himself, his leg, on a fence, and he had a pretty good wound there. And I got the vet there, and I said, I'm not up to date on my tetanus vaccine for him. And says, no problem, I've got some tetanus vaccine with me, but let's go ahead and give him tetanus antitoxin now. So here's what tetanus antitoxin is. It's basically antibodies against the toxin, the tetanus toxin. It's been created in a lab, okay? So you get an injection of tetanus antitoxin, and what it does is it puts those antibodies into your bloodstream. If those antibodies encounter any tetanus toxin in your bloodstream, it's going to bind to it, it's going to inactivate it. So that's to keep someone from getting sick if they've gone too long with their tetanus booster, all right? So you do two things. You give them antitoxin to stabilize them, and then you boost them through their vaccine. So this is perfect nursing application, tetanus. So let's look at the flip side of this. How about some toxins that are acetylcholine blockers, antagonists? And I've got a clinical app online for that. So the presentation of someone with this kind of toxin exposure is not enough acetylcholine, all right, acetylcholine insufficiency. So let's start with botulism, common enough that you'll see it as a nurse. Now, botulism is produced by a bacteria called Clostridium botulinum. Now, again, it's the toxin this bacteria makes that's the problem. So the toxin prevents acetylcholine from leaving neurons. Remember when we talked about acetylcholine signaling? A presynaptic neuron has to release that acetylcholine to cross the synapse to bind to a receptor, okay? If that acetylcholine is not allowed to leave the synapse, allowed to leave the neuron, it's never going to cross the synapse. It's never going to bind to a receptor. It just stops it completely. So what you see in a person with botulism toxicity is they have, I don't like flaccid paralysis, I like hypotonia. Remember, tone means muscle tone, and hypo means too little. So botulism can definitely harm you, okay? Now, you can get it from improperly canned foods. That's usually how most people get it, and it is rare. Another way you can get it is if someone uses botulinum toxin in Botox. So that's the little injections of, it's supposed to be in a non-toxic form of the toxin, one that won't induce botulism, but it's meant to relax muscles around your eyes and face to smooth them out, so it's a beauty treatment, right? If someone gets Botox from an unreputable source, like someplace online that's not a pharmacy, you could get Botox that actually has some active toxin in it, and you could give yourself botulism. So you might sometimes see that as nurses. Now, paralytic shellfish poisoning. I've got an online app for that as well. Now, would you as nurses see paralytic shellfish poisoning? Quite possibly, because we have coast in South Carolina, the ocean, and people do go out and harvest shellfish. Those are like bivalves, like oysters and things like that. Well, every now and then, there'll be what's called a red tide, and that means overgrowth of red algae, and those algae release a toxin into the water called saxitoxin. Now, normally the level in the water is not harmful, but these filter-feeding shellfish filter the water for food, and in doing so, they build up higher levels of saxitoxin in their tissue through filter feeding. So if you eat a shellfish that has ingested saxitoxin, you're going to get a high dose of it, and that could give you paralytic shellfish poisoning. So that's why when there is a red tide, they'll put out a sign saying no harvesting shellfish from here. The area is closed. Don't sneak in there and go harvest shellfish, not unless you want paralytic shellfish poisoning. So what it does is it works differently than botulism. It blocks the acetylcholine cholinergic channels. It prevents the sodium channel from opening, or prevents the sodium from getting into the cell. So if acetylcholine still crosses the synapse, it can still bind to a receptor on muscle, but this toxin prevents the sodium channel from opening up. So without that sodium entering your cells, they're not going to be stimulated. So it prevents skeletal muscle contraction, and it causes hypotonia. All right, the last one I don't think you'll ever see because, well, how often are you going to eat pufferfish? I don't even think they sell at any sushi place that we had in the PD. But fugu are pufferfish, and they produce a toxin that's called tetrodotoxin, and it is very deadly. In fact, if you ate so much as a little bit of the fugu pufferfish gland, it would kill you. That's why sushi chefs have to be licensed to cook fugu fish. But what it does is something similar to what happens with paralytic shellfish poisoning. It prevents that sodium ion channel from opening. Without the sodium coming into muscle cells, they can't contract, and it causes hypotonia. Okay, well, we've got a couple more disorders now. We're done with talking about toxins. We're going to talk about some other disorders of acetylcholine signaling. So, myasthenia gravis. It's common enough that you'll see it as nurses. I have a clinical app online for it, but what it is it's your immune system is attacking your cholinergic receptors on your muscle cells. And so what we see here on the left is normal acetylcholine receptors on a muscle cell, and here's the neuron releasing acetylcholine. All right, so on the left, that's all normal. On the right, this little inverse Y thing, that's an antibody, and that's attacking the receptor. And once those receptors are damaged, they're done. You're not going to grow new receptors. So left untreated, this would be a progressive condition. So without enough acetylcholine receptors, you have muscle weakness, okay? The acetylcholine is being released. It's crossing the synapse. The problem is you're losing receptors for it, and so that's why you get muscle weakness. And left untreated, eventually a lot of them could be destroyed. So I have here muscle weakness. It usually starts in the limbs. Also can even go after the respiratory muscles. And I say here, swallowing problems. I actually knew someone who had this in a retirement community, and that's how he died, is he choked. He aspirated food and he choked to death. The muscles in your throat, the pharyngeal muscles, are used for swallowing so that your epiglottis covers your airway when you swallow. Well, if you have reduced muscle function and weakness, even your swallowing muscles get weak and they don't work as well. And so you can have choking hazards with this disorder. Okay. Alzheimer's. What's happening here, unlike myasthenia gravis where the cholinergic receptors being destroyed, with Alzheimer's you're losing acetylcholine producing neurons in the brain, and once they're gone, all right? You're not going to grow new ones. It's also more recently been found to do with too much glutamate. Glutamate is always stimulatory in the brain, but too much of it is a bad thing. So on the left down here in the lower image, we've got a normal brain, and the bright areas indicate areas of high metabolic activity. You see his brain is lit up, all right? After Alzheimer's, especially untreated, has gone, you notice in the right-hand image, less parts of the brain light up. The dark areas are where enough acetylcholine-producing neurons are gone, and so the brain can't be stimulated there. Okay, so we've got two disorders here. I'm going to ask you a question. If in myasthenia gravis, your immune system is attacking and destroying receptors, is there a common pharmacological drug that you could give a patient with myasthenia gravis to slow the progression of this disease? How about an immunosuppressant? Immunosuppressants are used to help people with myasthenia gravis to slow your immune system down so it stops destroying those receptors, okay? So that's a common treatment. Now, Alzheimer's, the problem is you've lost acetylcholine-producing neurons, and you've got too much glutamate. So you might want to treat, let's see, what would you give a patient with low acetylcholine, like Alzheimer's, or they've lost acetylcholine receptors, like myasthenia gravis? Well, one treatment that you can give someone with myasthenia gravis is an immunosuppressant to slow the immune system down. There's other treatments too. So you could give these patients an acetylcholinesterase inhibitor. Oh my God, I thought acetylcholinesterase inhibitors were bad. They're bad if you're exposed to an organophosphate pesticide. They're bad if you're exposed to, like a pesticide used in agriculture, or it's bad if you're exposed to sarin gas. Yes, but if you've got a disorder where you don't get enough acetylcholine, like myasthenia gravis, because the receptors are being destroyed, or like you're losing acetylcholine producing neurons in the brain, like Alzheimer's, you can give them an acetylcholinesterase inhibitor, which will prevent acetylcholinesterase from breaking down acetylcholine. Acetylcholine builds up in the synapse and helps them. Okay, so it helps treat the disorder. So now I've given you a flip side. Here's an acetylcholinesterase inhibitor bad. Here's when it's good. All right, so for Alzheimer's, they typically prescribe these types of drugs. You're not going to have to memorize that. For myasthenia gravis, they prescribe neostigmine and pyridostigmine. Those are very common drugs. And so in Alzheimer's, it promotes more acetylcholine activity in the brain by preventing its breakdown. And for myasthenia gravis, it again prevents acetylcholine's breakdown, so there's more of it in the synapse. So that the few remaining cholinergic receptors that are present, there's a lot of acetylcholine to stimulate those fewer receptors, so that's how that's working. Okay, so whenever you prescribe a drug, it treats one symptom and then it has these side effects, right? These drugs have a side effect. So I'm going to give you a little intro into nursing pharmacology. Acetylcholinesterase inhibitor causes more acetylcholine-like activity. If you have low acetylcholine to begin with, this can help you. However, there are side effects. Maybe your memory and cognition would get better in Alzheimer's. For myasthenia gravis, you might have better control of your skeletal muscles. But you also have extra acetylcholine that can give you a dumbbell's cholinergic syndrome effect. So you might have a lowered heart rate. Your gut might be overactive. You might have excess urination. You might even have bronchoconstriction. So now you got to give another drug to treat those dumbbells-like symptoms for the primary drug. So what drug could you give to stop the bradycardia, slow the GI system down, and to decrease the urination and bronchoconstriction? If you thought atropine, you're right, because it will block the muscarinic cholinergic receptors, not the nicotinic ones, okay, on your skeletal muscles. Okay, now, I'm not going to show it here, but for your own learning, I got a YouTube video link here to an actual nurse who is going to explain the problem with acetylcholine signaling in myasthenia gravis and the role of drugs like this. Okay, but you can look at that on your own. Okay, well, this seems like a good place to stop, and I'm going to post this video, and then I'm going to make a new video for the remainder of the PowerPoint. But I hope that explains a good chunk of acetylcholine signaling, the normal process, how it happens through nicotinic receptors and muscarinic receptors, and then when we have acetylcholine signaling gone wrong. All right, hope you enjoyed it.